Good evening, everyone. Welcome to Master Classes in Critical Care Medicine from Yashoda Hospitals in association with the FCCM Hyderabad chapter. Today we have a very interesting case discussion, brain death declaration and organ transplantation. The students who are working in transplant units, they have more exposure, but those who are not working in non-transplant centers, especially for them, it will be useful. For this, we have a very senior examiners, Dr. Gopal sir. He is considered as first transplant intensivist in India. And very senior another intensivist from Kolkata, Dr. Arindam, both are the examiners. And case will be presented by Dr. Prasad Reddy from Citizen Hospital. And another student is Dr. Vignesh. He is from Yashoda Hospital. Dr. Prasad, you can start the case.
Thank you, sir.
Okay, Dr. Mani, I think the scheduled time, good evening to everyone. The scheduled time is about 1 hour. So you start presenting the case, and is Vignesh going to present anything?
No, sir. He will just join.
Participate in the question. Okay, we'll point out the question to either Mani or Vignesh. Okay, so you may present your case now. Are you okay with that, Arindam?
Yes, sir.
Yeah, thank you. Go on, Mani.
Yes, sir. Good evening, all. Today I'm going to present a case. A 28-year-old male presented with left-sided weakness, urinary incontinence, who was found in gym bathroom shortly after lifting weights. Presented to the emergency department. Upon arrival to the emergency department, he is following commands with left hemiparesis. He complained of severe headache. Coming to physical examination in the emergency department, vital signs were as follows: temperature of 95.5 degrees Fahrenheit, blood pressure of 160/90 millimeters of mercury, pulse of 63 per minute, a spontaneous respiratory rate of 20 cycles per minute, and oxygen saturation of 98% on 3 liters of oxygen via nasal cannula. His lungs were clear to auscultation bilaterally. He had a regular heart rate with normal S1 and S2, no appreciable murmurs, rubs, or gallops. His abdomen was soft, non-tender, and non-distended with positive bowel sounds. He has no lower extremity edema, normal peripheral pulses. His GCS was 15 and he had a dense left hemiparesis, but was able to move his right side against gravity to commands. His speech was fluent. He had right gaze preference. His pupils were 3 mm, equal in size and equally reacting to light bilaterally.
Wait a moment.
Sir.
What's your immediate response to your patient as the first responder?
Sir, I'll assess the GCS initially. I'll try to assess the hemodynamics, airway, breathing, circulation, the patient, and immediately I'll think of any CNS pathology in these patients.
Why?
Because he has left hemiparesis and he presented with severe headache.
And taking the patient's characteristics, demographic and physical characteristics into consideration, what CNS pathology would you consider in order of preference?
So he's a young patient, 28-year-old male. I'll consider any he's any congenital malformations in the brain.
Like what? Congenital malformation, like what?
Yeah, AV malformations.
What are the incidents of congenital malformations in a 30 years old Indian fit male?
It's very rare, sir.
Sorry?
Very rare, sir.
Do you have any number on the top of your mind? Percentage of 1 in 1,000, 1 in million, whatever?
No idea, sir.
Okay, what is your first is congenital malformation. What type of congenital malformations? Can you be more specific? Someone of 30 years of age, otherwise fit and healthy, is actually in a gym, he said. So What kind of congenital malformation and its complication can cause this clinical picture? When you say congenital malformation, there are several structures in the cranium, isn't it?
Yes.
So,
Vascular malformation, sir.
okay.
And on presentation, his BP was high. So suspecting a hypertensive bleed on top of a vascular malformation.
Any particular name of the vascular malformation? Again, vessels, when there are various kinds of vessels.
Aneurysms.
Okay, aneurysm of what vessels? How many types of vessels do you find in the body, including brain? Go on, you said something.
Arterial aneurysm, sir.
Okay. Speaking of arterial aneurysms, which arteries in the brain are more common to have aneurysms? Any incidents about that you can remember? No, you know the arterial vascular. This is a very common question. You know the kind of blood vessels, arteries, especially present from. I request people not to put charts, please.
All right.
No charts.
I think he can go back and read, sir. I think he had been pushed. My only one more observation, if you have not done a little more detailed, as this is primarily.
Vignesh, would you like to add anything while Arindam comes back?
No, I'm back, sir.
Okay. Come on. Sorry for that. Yeah.
More detailed neurological examination would be, I think, more befitting to it. Power, tone, deep tendon reflexes, right, and all of that. Because it's a little he's 15 by 15 with hemiparesis or hemiplegia, whatever. So a little more detailed neurological examination had to be done.
Right.
Fair enough. I think what could be your differentials then? One is as you told, your any congenital AV malformation related bleed, or maybe an undetected hypertension and then hypertensive bleed, right?
Yes, sir. Any ischemic stroke?
Any other differential?
Ischemic
stroke in a 28-year-old, okay, can be a possibility, but not so common possibility in terms of maybe some sort of acquired hypercoagulable state or something of that. So he's a 20-year-old guy. Yep.
Maybe he had a slip and fall in the washroom, sir.
And but what would be your, as an intensivist, right? As you are giving an exams for intensivist, what would be your priority? Because this guy doesn't slip to be in an acute emergency. Is he so? Is he in a precariously positioned situation, or he is stable?
He's stable, sir, at the time.
Are we all sure about it?
Yes, sir.
Someone is a 15, but complete hemiparesis, you said, right?
Yes, sir.
One side. I think we should be little careful before declaring him on an A, because I am anticipating he might deteriorate in coming hours. Unless we very fast come to a pinpoint diagnosis what is happening and whether that diagnosis or that pathological state is stable or not.
Right.
Fair enough. I think you proceed.
Yeah. So you had put AV malformations as your number one possibility, second as a stroke. Anything else? Let us get on with this quickly so that we can go to the core subject.
Yes, sir. Trauma, sir. Maybe slip and fall in the washroom. Sir.
Yeah. What is the consequence of trauma? Slip and falls. We see so many cases. What will happen inside the cranium?
Any concussion injuries?
Okay, concussion. What next?
Any bleed, sir?
What kind of bleed?
ED.
Yeah, the question is, what is ADH? Would it fit into this picture of GCS of 15?
No, sir.
No. So that's why you put it low down in the priority. I appreciate that. So proceed. What happened next?
Yes. Coming to past history, he's a known case of bronchial asthma on inhalers, and he's a smoker, sir.
Okay.
Initial laboratory values white blood cell count of 11,800, hemoglobin of 4.1, hematocrit of 35.7, platelets 3,46,000, prothrombin time of 14.5 seconds, partial thromboplastic time of 27 seconds, INR is 1.1. Blood urine nitrogen 24, sodium 136, potassium 3.8, chloride 101, creatinine 1.5, sir. Glucose.
Go back by a slide. Go back by a slide. What is the relevance of prothrombin time and partial thromboplastin time in this case?
Any coagulation abnormalities.
Why should you have a coagulation abnormality?
Causing a spontaneous bleed.
Why should you have a coagulation abnormality? In this particular case, anybody can have a coagulation abnormality. I agree. I can have. You can have, but why this man? This particular case which we are discussing. In view of intracranial pathology. Or people with intracranial, can you hear me, Mani?
Yes, sir. Yes, sir.
Yeah. Or people with intracranial pathology prone to have any coagulation abnormalities?
Usually, any trauma can cause coagulation abnormalities, sir.
Just a moment. Let me take a small break. Shashidhar, can everybody hear us? People are going and putting chat box answers.
Sir, actually, whatever opinions they have, they will share, sir. If any questions are there, we will answer at the end. Any interesting questions?
I'm not concerned about that. This is the lead point to the two examinees.
Yes, sir.
Anyway, let us proceed with the work. So, yeah, Mani. The question I asked is intracranial pathologies. Can people have any coagulopathy?
It can cause DIC, sir.
Why? Vignesh?
No, sir.
Any idea, Dr. Vignesh?
No, sir.
No, I think you should read up on that. Okay. We are not in the right now. We're not in the job of answering. We'll see at the end of the case. Okay, proceed next to the next slide, please.
Initial ABG, pH of 3 liters of oxygen, pH of 7.38, PCO2 of 42, PO2 of 165, bicarb of 22, base excess of -1. Urine toxicology including alcohol, amphetamines, barbiturates, benzodiazepines, and tetrahydrocannabinol were all negative in chest X-rays. Porcine Hospital, emergency non-contrast head CT and CT angiography of the brain was planned, but patient became more lethargic. He was subsequently intubated for airway protection with propofol and rocuronium and shifted to neuroimaging. This is the CT non-contrast CT brain.
Okay, can you explain that CT to us, please?
Yes, sir. There is a right frontal hematoma, sir, causing a midline shift with perilesional edema, sir. The blue arrow shows the hematoma, and the red arrow shows the midline shifts.
Any other comments?
Diffuse edema is there, sir.
Yes,
Yeah.
whenever you are commenting on any CT and whenever your intent is to describe about the raised intracranial pressure, so not only midline shift, we always comment about the ventricles, effacements, and sulci gyri in gray matter, white matter differentiation. So these are your points which actually indicates that you are aware about the raised ICP and you are prepared to deal with that. That's how you complete your answer. And always try to comment also on the quantum of the midline shift, whether it is a significant, that means you will act much faster than usual. So a right-sided intracerebral frontoparietal bleed, probably hematoma, with a significant midline shift with loss of sulci gyri differentiation, gray matter white differentiation is still there, and with ipsilateral ventricles completely effaced. So that's how you answer completely with scoring all the points and impressing the examiners.
Right. Could you answer in the terms of what Dr. Arindam Kar has just asked? You are saying midline shift, how much, etc., which we do in our daily practice.
Yes, sir. This is a CT, non-contact CT showing right frontoparietal bleed with perilesional edema and midline shift. There is effacement of the sulci and gyri, sir. And the right side ventricle, there is effacement.
Okay. What is the action that you want to take on the results of this particular CT scan findings? Of course, in consultation with your neurosurgeon.
Sir, initially, I'll discuss with the radiologist about the midline shift, sir. It's around 5 mm, sir, this patient. So I'll go conservatively, and I'll inform the neurosurgeon, discuss about the CT scan.
When would you not go conservatively?
Midline shift is more than 5 mm. I'll intervene, sir.
Okay, what interventions would you consider?
Decompression craniectomy.
Okay. We won't discuss much on that because today's topic is not head injury management. But can you briefly, I'll go to Vignesh at this point. And Dr. Vignesh, can you briefly tell me in 1 minute, what are the advantages and disadvantages of decompressive craniotomy according to standard literature, evidence-based literature?
Doing decompressive craniotomy has shown mortality benefit actually if we do early actually, and in this case the GCS is actually 15/15. We can hold on for a minute, but if there is any drop in GCS further, discussion with the neurosurgical team, the patient has to be taken up for decompression craniotomy.
No, excuse me. At this time, patient is not 15/15. He's already intubated.
Yes, sir. Yes, sir. Yes.
Some time ago, Dr. Mani told us that the patient became lethargic and started.
Yes, sir.
He was intubated. So keeping again in that view, that's not what I'm asking. What I'm asking is, if we have taken a decision to intubate this patient, if I am the patient relative, I am asking you, what are the advantages and disadvantages of decompressive craniotomy? And what is the purpose of decompressive craniotomy in this patient?
Disadvantages will be there is increased morbidity in the patient, sir. And advantages will be, yes, we are able to relieve the pressure and further, which is causing further damage to the normal brain, which is being done.
Is that the purpose of decompressive craniotomy?
To relieve the intracranial pressure, and there will be an extension perilesional edema will be there.
Is it going to reduce the edema? Decompressive craniotomy.
It is not going to reduce the edema. It is going to give space for the brain actually.
And prevent what?
Further secondary brain injuries.
Like what? Such as? Come on, you're saying something.
It prevents further brain injury causing herniation or a further increase in ICPs.
Okay. Okay, that's great. Go back to Mani. Go on, Mani. What happened next?
These are the imaging findings. Vasogenic edema, right to left, midline shift of 5 mm.
You told that already. Go ahead.
This is the CT angiography showing AV malformation, sir. The right arrow suggests a tuft of vessels showing suggesting of AV malformation. Prominent angle of vessels located at the middle aspect of the right frontal hemorrhage, suggesting an AV malformation.
So your
P1
suspicion was correct. Okay.
Yes. Patient was shifted to ICU and continued on mechanical ventilation. Intravenous 3% saline was administered as infusion to maintain a serum sodium range of 150 to 155 milliequivalents per liter. Propofol infusion was titrated to maintain deep sedation. Over a period of 2 months.
You want to ask something?
Sir, I think I was tempted to ask many questions,
Yes.
but as our topic is on brain death, so I think we should allow the patient to go towards that so that he can actually have certain questions on that part.
Okay, I think we'll arrive there very soon. Go on.
Over a period of 12 hours, while in the ICU, the patient's GCS declined further. A repeat CT scan brain revealed worsening of the bleed and increase in the midline shift of 12 millimeters. Patient underwent an emergent right frontotemporoparatal decompressive craniectomy, shifted to ICU back.
Okay.
Day 2 in ICU. In ICU, he was continued on mechanical ventilation with his GCS. His GCS did not improve. Sedation was stopped. His GCS was 3/15, and on examination, pupils were 5 mm, bilaterally and not reacting to light. Heart rate of 60 per minute, BP of 130/90. Temperature, he was afebrile. Saturation of 90% on FiO2 of 0.4, PEEP of 6, rate of 18. Repeat CT scan brain on day 3 of ICU revealed a massive rebleed. He was continued on mechanical ventilation. On examination, his pupils remained dilated and fixed. Response to noxious stimuli was absent. Attenders were explained about the poor prognosis of patient. All the clinical.
One minute. Go back. Okay, I am the patient's son. You are saying poor prognosis. Explain it to patient's brother, maybe. He's too young to have a son. What do you mean by poor prognosis, sir? I don't understand that. You did 2 operations on him, 3 scans on him, and now you are saying it's poor prognosis. What prognosis of what? I mean, can you be more elaborate?
The patient had a bleed in the brain, sir. So initially we thought we manage it by conservative management, but the patient has a rebleed in the repeat CT brain with a drop in. There is a drop in his conscious level sensorium. So we intervened and did a procedure to relieve the pressure on the brain. So that we expected an improvement in his brain condition, but eventually the bleed worsened. Even though we have done an intervention, now patient sensorium is very poor. So the chances of him to recover are very less.
Recover from what? What do you mean by recovery?
The brain function recovery.
Can you be more clear on that? What do you mean? He's going to be okay, but he's not going to be conscious, or consciousness is going to slowly come back after a few days or weeks?
The conscious levels are not going to come back, sir, in this kind of bleeds.
But he'll be alive.
Practically, we have to do some tests, sir.
Oh, okay. What a test for what? You have already done 3 CT scans.
We have to clinically assess the patient.
For what? We have allowed you to do whatever you want to do till now, and you are saying the outcome may not be good, but you are saying you have to do further tests. I'm getting very confused here. In fact, I'm getting very worried too.
But sir, can I speak a little?
Yeah, of course.
Yeah. I think in all the DM, DNB and fellowship exams, guys who are there, I think you will have a completely separate OSCE or a set where there would be professional actors sitting down and acting on behest of the family or whatsoever. And there is a little different. I think our master class could have a separate communication set. There would be a lot of, because in this case scenario, communication and counseling and consent process is, if not the most important aspect, right? So there are certain rules of communication on this sort of tricky situations or complex situations where you introduce yourself, make them comfortable. You ask if someone else would be also there, because it's not an individual decisions and all this stuff. And you have to be very, very patient, and time and again make them understand that all the efforts had been given, and a complete team was involved. The best people were involved. The whatever could have been done in the modern medicine was done. Then unfortunately he didn't respond. Things went more complexities, and it seems to be, and do not say very harsh words that there is no chance, no hope. There seems to be not very hopeful situation for him to eventually have a meaningful life. So like tend to use words which are more acceptable to people, right? More soothing to the ear of a family who is going to almost lose a member of them. So that's sort of an A. And the trick in this say, because now that we have understood, not because of our topic, this guy is a potential organ donor. He's only 28 with everything healthy, right? And he is a potential organ donor for multiple organs and multiple lives. So here, the first counseling is the most important aspect in real life also, because there you have to gain the confidence of the family in that way. So that's what Palepu sir is trying to poke you in, that you have to gain the confidence. You have to, not only you are sort of trying to win a losing battle, but you have to also get into confidence and convince them.
Manish, so that is the basis of counseling at this point of time.
Yes.
Apart from the technical sides of the brain death and organ donation, which are very important. Before donation, the pre-donation phase, counseling is the game changer.
Yes.
It is only counseling which produces organs, not your brain death declaration, not loss, not money, So you have to be very careful when you use this word prognosis here. That's why I'm kind of teasing you on that particular aspect. So when you are going to tell the relative, please tell me. Now let us turn to Vignesh for a moment. Vignesh, what would you tell the patient relative about the prognosis?
So the patient had a bleed already. We did
all that is okay. We are purely going to prognosis now. That has been told.
Yeah. So from this point, the neurological outcome, as in he coming back and speaking to yes, or it's going to be a normal, leading to a normal. It's not going to be possible in his case. So from this point, there is a possibility that he may even have even a cardiovascular collapse is also a possibility, because there has been signs which are able to see. And we have to proceed with apnea testing in him.
Would you directly go to that? Would you directly go and say the prognosis is poor, I want to do an apnea testing?
We'll confirm a few things before that, and then we have
how would you know how the family would react? In a single sitting at the end of your medical suspicion, the patient may be brain dead, you are facing the patient. Of course, you must have met the patients a few times about the decompression, if not your team members. But if you suddenly go and tell them that I'm going to do an apnea testing, the whole scenario will change, isn't it?
Yes.
How do you know how the family, is there any way of predicting how the family would react?
I think that your approach should not be like this. Palepu sir is absolutely bang on it, because moment you say this sort of points, the entire thing would be reversed. So rather you would say that there is a almost very, very little chance of having almost to have a meaningful neurological recovery leading to an independent life or restoration of his previous health. And despite all our efforts and everything, it is very unlikely that we can reverse the situation he is now. So what we will still involve certain people to assess the condition, whether we can reverse this or it can go more down or more complicated than whatever is happening. So that is that where you are indicating that you are implicating certain people to do one rather than telling on their face that apnea test and all others, right? And in the subsequent counseling, slowly, gradually, you will unveil the possibilities that why you are considering cerebral death. One is discontinuation of therapy eventually by declaring cerebral death if the family doesn't agree to the organ donation. And if they accept the cerebral death, then only you can bring in the concept of the living through others, where you actually explain that, yes, now it's time that we can think that if we cannot save his life, he being into others can save multiple lives. So that's how the approach should be.
Yeah, the most important word that Dr. Arindam has uttered here is subsequent counseling. You see, you cannot approach this kind of scenario in a single counseling, and moreover, you can never approach alone. You have to take a team, and subsequently in 2 or 3 counselings, slowly break the news and then tell the process. You have to make the patients calm down, patient relative calm down, and understand that they are coming to an end point, which is not really an end point. Okay, let us go forward, Mani. That is about counseling, but there are more things to discuss.
So all the clinical tests for brainstem reflexes were negative for the patient. Apnea test was performed along with the neurosurgeon, which is positive, and second apnea test done after 6 hours is also positive, and he was diagnosed as brain death.
Okay, let me ask you one question here, Dr. Mani and Dr. Vignesh. Before you do brain stem depth test, okay, you're suspecting brain stem depth, isn't it? That's why you're doing all these tests. What is the accepted legal definition of brain stem depth?
So cessation of all the reflexes permanently and irreversibly is a brain death. Defines brain death.
That's all.
So there should be an evidence of for the explaining the coma. That may be a neuroradiological evidence testing coma, and we have to perform the test for the brainstem reflexes.
Do you need to seek patient family's consent to do brainstem depth test?
Not necessary, sir.
Not necessary. So, Dr. Vignesh, I will take you on now, and after I ask one question, I will ask Dr. Arindam to proceed further.
Sir, one more question is there, that prerequisite for a brain death assessment.
Yeah, we'll come to that. I want to ask a legal status question to Vignesh. Dr. Vignesh? Yeah, 1 minute, Dr. Arindam.
Yes, sir. Sorry, sir.
Dr. Vignesh?
Yes, sir.
Under what law are you declaring a patient brain dead in the country of India?
In 1994, Transplantation of HDHO Act has been passed. Under that law only, we are actually declaring a patient as a brain death or brainstem death.
Okay. What was defined in that law?
There should be, it's basically a clinical test, purely based on a clinical testing, sir. There should be an, as he already mentioned, there should be an irreversible and irreversible brain damage should be there, sir.
Okay, fine. That's fine. That's fine. We'll go to Dr. Arindam. Arindam was asking something.
I have asked that prerequisite before approaching for a brain death. One, you said that there should be a clinical scenario, and there should be some sort of structural your neuroimaging, which corroborates with the possibility of a brain death. Anything else?
There should be, we should exclude all the other possibilities, like any other toxin ingestion or any, not in this case.
So and, any other reversible cause of brain death, right? So there could be a number of sedation, toxicology, pharmacology, hypothermia, extremes of acid-base imbalances, electrolytes. So this all you have to tick all the boxes, right? So this is a very important aspect. You cannot just think that I would do a brain death testing and all that. So you have your answer has to be very structured, both of you, right? Think before you answer. So these are the 2 three things before initiating a brain death or brain stem assessment on that part. Fair enough. I think the laws are also important, and our brain death assessment is heavily relied upon or heavily borrowed by or followed by the American Association of Neurology, Dr. Vignesh, the initial criteria. So you guys, all of us must memorize it, not only read, memorize it point to point. And everywhere in the world, it is the most followed upon brain death guidelines or criteria. And the laws, there 94 was the initial law. There were multiple amendments or rulings by the Honorable Supreme Court. A little bit of idea on that, because you are going to be submitting for the highest level of exams. So as Sir told, just have an idea of the Indian legal standpoint on brain death and organ donation.
Right. Now, coming to the process of brain death, Dr. Mani, who can conduct a brainstem death test?
Sir, for diagnosing brain death, there should be two doctors, sir. One should be an intensivist, and the other person should be a neurologist or a neurosurgeon, sir. This is for diagnosing brain death.
How many times you should do it?
So usually 2 times we have to do it, sir, with an interval of 6 hours in between the tests.
In all age groups?
No, sir. In pediatrics, pediatric age group.
In pediatric age group is different, sir. More than 30 days to up to 18 days, they have told it should be 12 hours, and less than 30 days should be 24 hours apart.
Now, is a technical test, so-called ancillary test, necessary to declare brainstem death?
No, sir.
In which circumstances is an ancillary test necessary?
So in road traffic accidents causing cranial nerve damages, any damages to the nerves or the organs which interfere with the performing of this cranial nerve examination, we can go to the ancillary test, sir.
Okay. So, Dr. Vignesh, again, can you tell me in detail, how do you conduct brainstem death test? You got about 3 to 4 minutes.
So to start with, we'll examine all the cranial nerves, sir. Starting from pupillary reflex, we'll just shine the torch over the eyes of the patient and look for a pupillary constriction. Secondly, we'll do an corneal test we'll be doing, sir. We'll just take a wisp of cotton and place it over the cornea of the patient and look for any extraocular movements are present, sir. And then followed by, we'll do if the patient has an intact tympanic membrane, we'll do a calorie testing. We'll keep the patient in 30-degree position, and with cold water, we'll push the saline over 1 minute and look for any nystagmus present in the eyes. And if the spine is cervical spine is intact, then we'll go ahead for Dolce testing. We'll turn the patient's head to right and look for the movement of the eye along with the side of the movement or not. Finally, we'll do gag reflex testing. We'll place a tongue depressor on both the sides of the palate and stimulate the posterior neuron and look for there's any active cough or anything. Then finally, we'll go for active cough reflex testing, either with the suction catheter. We'll place it inside the tracheal tube, and then we check for reach the carina and then check for if there is any active cough present or not.
Okay.
All these things are negative. Then we will go ahead for apnea testing.
Just a moment. Before we go for apnea, choose any of the 2 cranial nerve tests, whichever you like, and tell me the afferent and efferent pathways.
Both the gag.
Don't choose the easy ones.
So for both the oculocephalic and calorie testing, the afferent is going to be eighth nerve, and afferent is going to be 6th nerve.
For both?
Yes, sir.
Okay. You read up on that. And Now, Mani, I'll come back to you. Tell me in clear technical detail, how do you conduct and interpret apnea test?
Sir, initially I'll pre-oxygenate the patient with 100% oxygen for around 15 minutes, sir. Later, I'll connect a pulse oximeter probe to the patient finger and then remove from the ventilator, sir.
It was not connected till now?
No, sir. Before doing, it was connected, sir. So we have to see the desaturation, sir. That's why. So I'll disconnect the patient from the ventilator, and I'll supply an oxygen of 6 to 8 liters through a soft tip catheter into the endotracheal tube, and then wait for 10 minutes, sir.
Any specifications about the soft tip catheter?
The internal diameter of the tube, there should be the catheter size should be less than 70% of the endotracheal tube in internal diameter, sir.
Why?
Because if we put a larger size tube, there will be CO2 retention, sir.
Okay.
Retention will be there.
Right. Okay, go on. So you have put the catheter and started insufflating oxygen.
Yes, sir. So clinically, by inspection, I'll see whether there are any respiratory movements, abdominal movements or not, are there or not. If the abdominal movements are there, that is the respiratory movements are there, and then I'll abandon the test. That is apnea test is negative, sir. And if the movements are not there, then I'll check for the desaturation.
How many movements you want to abandon the test?
Continuous cyclical movements, sir.
How many? 1, 2, 3, 4, 5.
One breath is enough.
Good answer.
Okay, even a single breath.
Single breath is enough.
Okay. What if the patient starts moving his toes during this test?
I'll abandon the test and then repeat the test again after some time, sir. Maybe it's a spinal reflex.
What is the meaning of spinal reflex?
After brain death, the rostral part of the spinal cord, it receives a blood supply till it will be receiving some amount of blood supply, sir. So there will be these spinal reflexes, and the other pathophysiological effect is from the increased PCO2 and ratio. It can cause spinal reflexes, sir. It's a normal phenomenon.
Can there be a sort of perceptible movement even after declaration of brain death?
Yes, sir.
What that this sign called?
Lazarus sign.
Lazarus. Right. And how would you explain to the family members? Because that could be a very devastating on that. So in many of the conversations, right, purposefully this sort of situation is actually pre-explained to the family members, that there could be certain reflexive movements on the spinal level and all others, which is not a meaningful, but still that could be an aim. So keep it in mind. This is what sir is trying to poke you, the spinal reflexes and the movement on that part.
Okay. So the patient did not breathe. What else?
Yes.
What next?
I'll continue to supply the oxygen for 10 minutes, sir. And see the after 10 minutes, I'll see the blood gases, sir. If there is a rise in the PCO2 of more than 20 millimeters of mercury, or from the baseline, we consider it as 40 to 60. I'll consider the test to be positive, sir.
That reminds me that before conducting the test, you did not tell me what is the prerequisites at baseline.
Baseline, we have to do an ABG, sir. PCO2 should be less than 40, and the patient hemodynamics should be stable. That is, the systolic BP should be more than 100, sir. And the patient temperature should be more than 36 degrees centigrade. These are the prerequisites for doing
Dr. Vignesh,
yes,
what
sir.
if the patient is a known COPD patient and his resting PCO2 was 54, 52, 54 before he became brain dead?
So then we look for increase in PCO2 of 20 millimeters of mercury from the baseline, sir. And then
He's
look
saying
for
the baseline should be below 35.
No, sir. In COPD cases, then on whom the pH will be normalized to increase CO2, where we will expect an increase, we will wait until there is an increase in 20 millimeters of mercury. And then even after that, with the pH of less than 7.3, and still there is no respiratory movement, then we can term the patient as apnea positive.
Let us say, Dr. Vignesh, this patient is also having some, when he's a smoker, right? This particular young man is a smoker. So during this brainstem depth test, he was not allowing you to proceed beyond 4 or 5 minutes of apnea. He was desaturating. What will you do?
Then I'll abandon the test as of now. And while proceeding to the next test, I'll connect the patient to the CPAP, sir, with 10 centimeters of water and 12 liters of oxygen. And then I'll proceed with the testing, sir, to look.
Okay. So when you're connecting this 13 centimeters of water of CPAP, patient BP is crashing. His systolic BP is going below 60.
If it is going below 60, again I have to abandon this test, sir. And then I'll proceed for any ancillary testing if possible, sir.
Okay, fine. What is the ancillary testings? Define ancillary testing. What are the tests? But before that, let us go back to money for a moment. So in your case, he allowed you to finish this 10 minutes of testing, and your PCO2 has crossed 20 millimeters of mercury, right?
Yes,
What
sir.
next? What next?
So, so we diagnosed the patient as brain dead, sir.
We already diagnosed it.
Yes,
This is the first test.
Yeah, first test, and then I'll conduct a second apnea test after 6 hours gap, sir.
But what will you tell the relatives between these two tests?
I'll set up a counseling with the patient attendants along with my colleagues or along with the neurosurgeon who has performed the test and who was involved with the patient since beginning. So we'll explain the patient attendants the patient condition is not stable and
Not stable.
The brain functioning is not there, so we'll be conducting some tests to declare him as a dead patient, brain dead.
But you have already done that. So will you say patient is dead or not?
No, sir. After conducting the second test, I'll declare him as brain dead.
So what will you tell the patient exactly now? What was the result of your first test?
So the first test is positive, and we need to conduct one more test after some time.
Why? You're not having confidence on your own test?
No, sir. As per the legal thing in India, we have to do 2 tests with a gap of 6 hours, sir.
Okay. Arindam?
Sorry, I was muted. So I think you have to be very specific rather than positive, negative, because positive can have a separate connotation to the patient. So you can say that our apnea test unfortunately points towards non-reversal of the cerebral function or the brain function, and it is not a good news for all of us. But according to the legal requirement by the Indian IPA or IPC Indian system, we have to repeat it, and if that also denotes this, then we have to think of non-reversibility of the situation. Do not utter that word brain death and all others unless you are absolutely sure and are going to declare it, right? So always use alternative phrases which are much more acceptable and soothing and gives you a space in case of some miracle do happen. So that's how you actually do both in exams and in real life. And limitations of apnea test, then your fallacies, the problems in apnea test. These are the areas where you would be very, very severely poked by examiners. Like particularly if someone who is as experienced as Palepu sir, who has been doing this for years in different continents, right? So he knows, he has seen thousands and thousands of the things that do go wrong in an apnea test or can happen in an apnea test, right? So your concept has to be absolutely clear about the limitations of it. and also on the ancillary testing. So there are no mercy for any major blunders over there, because in real life, if something goes wrong, it's a catastrophe, both in terms of medical legal as well as in a volatile situation, things can go out of hand, right?
I mean, let us say the patient family, as the Dr. Arindam was pointing out, accept it because you explained very nicely. And they're knowledgeable people, educated people. This guy goes to gym and all that. They say, look, sir, we know what happened. You did what you can. We're not interested in organ transplantation, all those things. Declare death and give us the body away. We'll follow our rituals. We have done only one test now, first test. What's your course of action?
So to officially declare the patient as brain dead, I have to do one more test, sir, as per the law. So I'll counsel them accordingly and proceed with the second test, sir.
Okay, that's correct. That's correct. Do you agree with that, Dr. Arindam?
Yes, sir, but I would rather say in two ways. One is not only the legal requirement, but there also this guy deserves there is a finite possibility at times people do respond between two tests. That is the reason that we give a time difference. So to sort of cover all the even impossible chances, but miracle do happen. So this time frame is given to conclusively rule out those type of possibilities, right? So this point has also to be taken care of. That will gain the confidence. Otherwise, what happens is many times people think anyway this guy is of no good, and the hospital is prolonging the entire process just to build up the bill or the money itself, right? So these are the 2 points you need to not only legal requirement, but also there is a clinical angle to it.
Yes.
Dr. Vignesh, while you are
Yes, sir.
waiting for a second team to come and do second test 6 hours later,
Yes, sir.
the patient develops cardiovascular instability, had
Yes,
a
sir.
cardiac arrest, and you could not resuscitate him. His heart has stopped. Now
Yes,
you have
sir.
to declare death. What death will you declare?
And the declaration time is going to be the time of cardiac arrest, sir.
So you declare a cardiac death.
Yes, sir.
Okay. What is the reason for that?
Because only after doing a second apnea time is actually declared as a time of declaration of death has been done, and then that is the time we call it as a neurological death. But in between something happens, it's going to be always a cardiovascular death.
Okay. Now you are mentioning the ancillary tests. Can you throw some light on what ancillary tests are available and what is their interpretation and validity from the most reliable to least reliable?
The most reliable is going to be DSA. That is what has been used as a gold standard. And if there is no absence of flow seen in the intracranial cavity after the scan, then we call it as the patient has no point of no return. And other test, what we do is transcranial Doppler. Again, it has its own disadvantage. You should have a good window in those patients. You should have already had seen a window in those patients, and they should have a reverberating flow. Should be there, and again the sensitivity specificity a bit lesser as compared to our routine.
What did you say after DSA? That is triple vessel cerebral angiogram, isn't it? What you're
Yes,
talking
sir.
about.
Yes,
What is
sir.
the next most reliable one?
Transcranial Doppler, sir.
Is it true? Do you agree with that, Mani?
EEG, sir.
No?
EEG is the least reliable, sir.
Scintigraphy.
No?
SPECT can be.
No. What about CT contrast? What about CCT? Multi-sectional spiral CCT?
4-vessel
If
angio,
we-
PET, or metabolic CT with the combination. I think all you guys have to read about the pros and cons of each confirmatory test, and there could be, obviously there is nothing which is 100% a combination of test in the context of clinical A, where the situation is little disputable, right, is going to be the answer. That I might have to do a composite test to find out the exact answer.
Right. So The order of test according to the, see, now there is almost evidence-based data on this. The percentages and confidence intervals and all those things are available. Please read up on that. Okay, this is the serial, and EEG is the most least reliable. Why? Why EEG is least reliable?
One thing here, what we're recording is only surface electrodes is there. Sometimes we can have an isoelectric EEG. And second thing is, if there is any confounding factors like hypothermia or sedation, again EEG can be isoelectric. So that is least reliable.
So okay, that's fine. So let us proceed to the next chapter of this. Mani, go on with your slides. Are there any more slides?
No, sir.
No slides. So what will happen after this?
So I'll declare the patient as brain dead, sir, after the second test.
And then?
And then if they're willing up for organ donation,
wait a moment, Dr. Apart from doctors, the medical specialists, who else will be involved in this case?
Transplant coordinator, sir.
It's mandatory.
Yes, sir.
Legally, it's mandatory that every transplant center and donation center should have a trained transplant coordinator who takes, because this is a matter of regulatory compliance. Okay. Now, then each one of you, starting with Mani again, because you are talking just now, tell me the regulatory network of organ procurement and donation in India.
There is a national organ transplant organization, sir, NOTO, and regional ROTO and state organ transplantation organizations. So I'll involve a transplant coordinator and counsel the patient attenders. And if they are willing for the transplantation and give consent for the transplantation, I'll inform to the local the police department.
You will do that?
Here we don't.
No, nowhere. See, once brain death is declared, your role is over. Your role will come a bit later. We'll have questioning about that also. You have no role to play in asking for organs or coordinating with the government or the regulatory organization. That's not your job, and you should not do it. Okay. Why you should not do it?
Then it will be like we do everything for the organ donation. It will be a misconception.
So what is wrong with that?
So that is wrong actually from clinical point of view as well, sir.
No. Is it clinics that is involved, or is some other point of view?
Patient attenders will lose faith on us.
Nowadays, nobody has faith on doctors anyway. So that's not the point. Why the intensivist who is involved in declaration of brain death should not be involved in requesting for organs? There is an ethical principle involved here. What is the ethical principle? We may be doing it offline, unofficially, but officially you're not supposed to do it. That's why the government has posted a coordinator. There is bias, isn't it? There is bias in judiciary responsibility. You know, someone has put it. There is a bias. The family will suspect and society at large will suspect that intensivists and neurologists are declaring brain death for organs. If you ask for organs, so that's not your job. You may help the system in doing so. In larger hospitals, we don't even go near it by that. In smaller hospitals, we have these dual responsibilities. Oh, lot of people there are in them.
Yes, sir.
You're back in hospital, right?
No, I am back in a meeting, and iske baad meeting chalu hoga. But I am listening to the entire.
Okay, so Arindam, take next 5 minutes on maintenance of donor, please.
ठीक है, sir.
Before you become busy.
I think, can you give an outline, any one of you, on the outline of what are the salient features that how you maintain a potential organ donor, and what should be your priorities also?
So initially, there should be a general ICU care of the patient and hemodynamic maintenance, circulatory maintenance, hormonal replacement therapy, the basic.
What do you mean by general maintenance? What components of general maintenance are you talking about? What are the problems you anticipate?
General infection control maintenance, like hand wash, patient, changing the position of the patient.
Hey, come on, don't boot around the bush. Come to the point.
Infection control prevention practices, WAP bundles, and routine.
Vignesh, just a minute. Let us be brain death specific here. We are not talking here about general principles of intensive care. This you use in everyone. Patient doesn't need to be brain dead to be followed infection control protocol, isn't it? Every patient. So we are talking here about brain death specific intensive care issues.
Maintenance of hemodynamic stability, maintenance of normal pH, normothermia, maintaining a urine output of up to 1 ml per kg per hour, and then hormonal therapies as well.
Okay, let us take one by one. What is the protocol of ventilating a brain dead potential donor?
I think you should start with the priorities. The priorities are the preservation of the organ as well as maintaining the dignity of the potential organ donor, right? Because he's still with us, he is still serving with his life for other people, saving other people's life. So that is a very important aspect, and also his organs are precious now, which can save multiple lives. And obviously there are sort of different hemodynamics, then hormonal resuscitation, then ventilation, and particularly in India now, your lung transplantation is very common, particularly where you belong. Hyderabad has led India in terms of lung transplantation. So all this, first you have to an overall plan that whether how many organs this guy can donate. Going by the history, it looks like he can donate almost everything, right from your heart, lung to liver to two kidneys to the cornea to skin to the others. In fact, the pancreas, the gut, everything can be LA. And then your entire perfusing that every individual organs without causing any overloading with the fluids or the tissue edema or under perfusing and creating ischemic changes is going to be your main over the motto of your management. And then we will go to the nitty-gritty details. Now answer, what should be your ventilatory strategy?
So the focus has shifted from cerebral protection to organ protection now, isn't it?
Yes.
So yes. During organ protection, Dr. Vignesh, patient is continuing to be on ventilator, right? Okay. What is the main difference between ventilating a head injury patient, or in this case a bleed patient, and ventilating a potential organ donor?
Concern. So. Yeah, 6 to 8 ml per kg of tidal volume should be kept for the patient and maintaining in this patient, sir.
Why?
Lung protective ventilation strategy, sir. Over tidal volume can cause, if the patient is going to for lung procurement, then we are going to damage good lungs. So that is not to be done in this case.
Okay, I agree with you. What else?
Rest all will stay same. Optimal PEEP to maintain oxygenation and normal pH will be continuing with the same.
How do you define optimal PEEP in this patient?
Maintaining a saturation of 90% SpO2.
90?
92.
Are you bargaining?
No, sir, 92.
No? Okay. Go ahead.
With the normal carbon dioxide, sir. The 35 to 45 will be maintaining. Ventilation is going to be that way.
Will there be any change in heart-lung interaction because of brain death? You said that optimal PEEP. That brings me to the focus of maintaining PEEP to maintain hemodynamics, isn't it? That's what it means, right?
Yes.
Yeah. So why are you particularly concerned in this patient?
Now we are going towards organ perfusion, sir. So,
Yeah.
so that's why we are more.
No, why in this patient? The same would be true in any patient. Let us say a pneumonia patient, let us say an abdominal surgery patient. The same would be true. But in this particular patient, is there further concern of maintaining so-called optimal PEEP, though the term optimal PEEP is becoming a bit outdated now. Are you more worried about hemodynamics in this patient? And if so, why?
More worried about hemodynamics because other organ perfusion also plays a.
I know, but I'm asking the scientific principle behind that. Honey?
So, we should maintain the adequate perfusion to all the other organs like kidneys.
I know that, but why particularly in this patient? Let us say oxygen has come down to 90 and one of your colleagues, neurosurgeon, has come and said increase the PEEP to 12. And you don't want to do that. Why you don't want to do that?
The potential person to donate all the organs, sir. So
I know, even your doorman knows that. Isn't it? Even security knows that this fellow is an organ donor and he should be taken care of. But why are you more concerned about heart-lung interactions in this patient as compared to a non-brain dead patient? Are these patients more prone to hypertension?
yes, sir.
Yes, sir.
Why?
Really, there will be a hypertension, sir, because of the surge, sympathetic surge.
Mm-hmm.
So subsequently, there will be hypotension, sir.
Why?
Surge, and there because of the
Vasomotor tone is going to be lost completely.
Sorry, I missed that. What did you say?
The vasomotor tone is going to be lost completely.
Yeah, it's as simple as that. Vasomotor tone has been lost, so heart-lung interactions are exaggerated in this patient. You will lose blood pressure very easily.
I think the moment they all read about the physiological changes that happens after the brain death situation, then that entire the corrective measures and those would be very easy to understand. That why what we counter actually.
Yeah. So, in other words, Dr. Arindam is asking you to describe what are the physiological consequences of brain death.
Yes. For example, there are 2-3 other reasons also. Loss of vasomotor tone, the hormonal changes, then acute dehydration that can happen because there is a dilutional, a lot of urine starts pouring out and there is an intravascular contraction. So a lot of things do happen. So once you understand the physiological consequences, once the brain death sets in, right, and then you can very well anticipate that what you have to do to counter that. So that's how you should approach. That this is only the physiological upkeep of a system, and while doing that, 2 things. One is you would be absolutely very, very careful not to introduce any infection, right? Because that will have a repercussion on the potential recipient. And secondly, not to set in any inflammatory response syndrome, not to set in any, for example, if you give very high pain, eventually not only heart-lung interaction, it will also induce a biotrauma, cytokine release, and distant organ injuries, right? So wherever you are just there to maintain the physiology, to counterbalance the consequences of brain death, and we just maintain the person or the perfusion, disturb and do not further disturb the internal milieu. That's a very simple way to approach it.
So, Mani, Vignesh has set up this, he came under pressure. He could not say no to neurosurgeon like the hospitals we work in. And he slightly increased his PEEP 8 to 9 or whatever. And patient started having hypotension. In other words, what I'm asking you is how do you manage cardiovascular disturbances in a potential organ donor who is brain dead?
So initially, I'll assess the fluid status of the patient. I'll hydrate the if the patient is fluid deficit, I'll hydrate the patient with the fluids.
What fluids?
My initial choice would be balanced salt solution, sir, like ringer lactate.
Mm-hmm.
and then after loading the patient with fluids, still if the patient is still hypotensive and I'll initiate a vasopressor, sir. My vasopressor of choice will be vasopressin.
Direct vasopressin? You'll directly start vasopressin on this patient. You agree with that, Vignesh?
We can start with the NORAD followed by vasopressin, sir, but upcoming evidence tells that going ahead with vasopressin as a first line agent prone to have more organ procurement and in recent times. So
Why wouldn't Noradil work properly in this patient?
there is active loss of vasopressin is actually there in post brain dead patients. So in these cases, the vasodilation is purely because of loss of decrease in vasopressin actually.
Yeah, but my question is not that. My question is, why wouldn't Noradil work in this patient? I agree with you. Noradil may not work very well in this patient. We used it for almost 3 decades, and now there is some amount of data supporting vasopressin, though there is a bit controversy about that also. But why wouldn't Noradil work in this patient? You're talking about autonomic storm, weren't you?
Yes, sir.
So what is the consequence of that?
Downregulation of receptors will be there because there we have an initial surge in all the catecholamine. There will be downregulation of receptors.
That's correct. That's correct. So there will be downregulation, burnout. It's a burnout of receptors basically. That is the reason why vasopressin. But what is the disadvantage of vasopressin? Mani? You only started vasopressin, so you tell me what is the disadvantage?
Renal constriction.
What else? More important than renal? More frequent than renal? In fact, there are studies to show that actually renal perfusion increases. But more important or more frequent than renal? More common than renal?
The liver
Splanchnic.
Splanchnic circulation will be reduced.
Isn't it? It is basically diverting blood from splanchnic circulation. So if you're going ahead for either liver or intestinal transplant, bowel transplant, there is a chance of bowel ischemia there. And in which patient, in which kind of patient wouldn't you start vasopressin?
In whom there is active DI along with hypotension.
Active?
Diabetes insipidus patient. So
you wouldn't give vasopressin to diabetes insipidus? Isn't that second line of choice?
If the patient is having both the diabetes insipidus along with the patient is having hypotension, so giving vasopressin in them will be a better choice.
Okay, not in this patient. This patient is a young fit man. But is there any other kind of patient in which you wouldn't use vasopressin? I'm not asking from brain death. I'm generally asking. What would you do before you give vasopressin to any patient? Even a liver patient. You take an ECG, don't you?
Yes.
Why?
To look for any ischemic changes, which is
yeah. So if there's a borderline myocardial ischemia, I will precipitate it. May not be in brain death because this fellow is 28 years old, young fit fellow. He may not have myocardial ischemia. So even after putting vasopressin or a bit of Noradil, the pressures are not picking up money. Are there any other agents that you want to use in this patient?
I'll add steroids to the steroids.
What is the basis of that? In brain death. I'm asking in brain death again. We'll come back to brain death.
I'll initiate hormonal therapies like T3, T4, and methylprednisolone. And
what is the role of methylprednisolone in brain death in general, not only in cardiovascular issues, but in general? Is there any recommendation about it?
procurement rate is higher actually when we are using steroids in these cases. So it is used as a control.
There is evidence that it can increase the chances of retrieval of the lungs, sir.
Okay. Okay, I
Yeah.
agree with you. How much and what steroid?
Methylprednisolone 15 mg per day, sir.
You were mentioning about some other hormonal therapy. What other hormonal therapy?
Thyroxine, sir. T3 and T4. Actually, T3 not available in IV form, sir. T4 here we'll use at 600 micrograms 8th early, sir.
What are the predominant electrolyte disturbances that you may expect in this patient, Dr. Vignesh?
Predominantly hypernatremia will be present in this case because of DI. Otherwise, hypernatremia, all the electrolyte abnormalities are possible. Predominantly, it will be hypernatremia.
What are the? Can you put some numbers on it and tell me what are the acceptable numbers and what will you do?
Sodium, I'll be accepting up to 155, sir. And if yes, sir.
So 157, you won't take the organs?
Don't take organs. I will try to correct it because there are some studies which state that more than 155 liver procurement is less actually. So I'll keep a target of 155.
So what are the absolute numbers above which you don't want to take organs? Sodium I'm talking about.
160, sir.
Single value?
160 to 170 is the value range, sir.
What is the single value and what is the serial value? Please read up on that. In serial values, even after correction, I think if it is more than 165, 2 or 3 consequent values, you won't take the organs. Or if it is absolutely above 170 in a single value or 175, I think you won't take the organs. But how would you correct it? Now the patient is starting to have DA, as Vignesh is repeatedly mentioning. He seems to be a fan of DA. He uttered it about half a dozen times in the last 15 minutes. So, okay, well, let us ask Vignesh only. How would you manage it? Hypernatremia in presence of DI.
So we'll start correcting with free water, sir, with 5% dextrose, or an RT will be giving free water through RT. And other than this, if the patient is immunologically unstable, we'll give vasopressin as well. Otherwise, we'll start the desmopressin spray 10 mics BD, or if IV preparation is also available, there we'll go with IV preparations.
Right. And let us say we're almost approaching that. I think Dr. Arindam has logged out. I will thank him for participating. The last few minutes we have left. Now, what are the latest developments? Both of you can answer one after another. In the technology to keep organs available for a longer time in a brain dead donor. With a brain dead donor. I won't use the word in, with a brain dead donor.
Cryonics, sir.
What is that?
Like preserving the organs at a very low temperature.
Okay, you reduce the temperature of the patient?
Yes, sir. It's an upcoming thing.
Is it done on a scientific basis?
No, sir.
Is there anything else that is being done on a clinical basis?
No.
Is there a technology which is available already? May not be in India, but why, Dr. Vignesh?
No, sir. I have no idea.
Any idea, Mani?
No, sir.
Have you heard ex-vivo techniques?
We'll read upon that.
Please read up on that. That is an advanced question, of course. It's not a pass or fail question. There are ex-vivo techniques coming up with patented instruments whereby the organs are taken out of the body, hooked upon to a bypass kind of system, ex-vivo, that is outside the explanted from the organ, and perfused, mainly for heart. It is being done. It has been done for liver also. I don't know whether it has been done for kidneys. Please read up on that, right?
Yes.
So, any further inquiries or questions from our colleagues or both the students and anyone in the audience? Dr. Shashidhar?
No questions, sir, actually. Arindam sir has in urgent meeting. So he told he will leave at 8 o'clock only, but he stayed for us till 8:15.
Yeah.
So 8:15 he left.
It's almost 8:20.
20.
The last question I would ask from both of you is, after brain death, what is the time period at which each organ can be accepted?
For kidney, it's 6.
There are clear-cut timelines defined, isn't it, for each organ? Let us say someone is brain dead for last 1 week. Would you take which organ? Would not take which organ? It is, of course, in a country like India where organ pool is very low. No? Do you know how much it is? What is the statistics of organ availability in our country?
Less than 2% organ procurement rate and all.
2%.
Yes.
2% is extremely high.
Less than 2%.
Even less than 2% is extremely high. That means in every 100 people, 100 persons, 1 person is donating. No, we calculate per million. In India, it is somewhere between 2.5 to 3.5 per million. Yeah. So it's extremely low. In a country, proactive country like Spain, for example, it is 35 to 40. We are so much less than them. Anyway, so in such country like ours, every organ is valuable. So we take very marginal organs. So in theory, it may not happen. In practice, it may not happen. But in theory, for every organ procurement, there is a time limit. And then a question also may come up about warm ischemia and cold ischemia times, because it is your responsibility till the organ leaves the hospital. Your team's responsibility, donor team's responsibility. So please read up on those things. They are non-negotiable numbers. Those numbers, right?
Yes, sir.
Any inquiry from Vignesh and Mani? Anything for the closing remarks?
No.
Both of you. Yeah.
So there are 2 questions, sir, in the chat box.
Mhm.
One is already answered actually. Why should there be a gap of 6 hours between 2 apnea tests? That is there. Actually, both the legal and the clinical aspects we have discussed. And another is one more question: is there any role of transfusion of blood or blood products in organ donor?
Mani, you want to answer that?
Yes, sir.
Yeah.
Maximum, if there is any coagulation abnormality, we can transfuse blood products.
That takes it to the very first question I asked you today. Why should there be a coagulation abnormality in a brain damaged or brain dead patient? Can you answer that, Vignesh?
DA, to incidence of DA is actually somewhere around 30%. I don't know the exact mechanism, but so those patients can have a deranged coagulation.
Yeah, the cerebral thromboplastin and some other molecule, I forgot the name of that molecule, we were discussing in one of our classes very recently. When cerebral damage, cerebral tumors, breach of blood-brain barrier occurs, coagulopathies can occur. Okay.
Tissue thromboplastin will be released.
Tissue thromboplastin will be released, and there's one particular molecule, there's a number. That molecule also is released. I'm sorry, I forgot the number. You can refer that. So these people can have coagulation abnormalities. Not only that, you have been ventilating this patient. Sepsis is a possibility. Coagulation abnormalities, thrombocytopenia is a possibility. And don't forget that this patient is going to undergo a surgery, a major surgery where he can bleed, where organs are retrieved. So if coagulation factors have to be corrected, they have to be corrected. And in the current scenario, what is the best way of getting a wholesome picture of coagulation profile?
TEG.
So TEG also plays a role in donor maintenance. We didn't discuss that, but that's a very valuable point. TEG also can play, and you can guess there can be necessary. But what is the trigger for HB in this patient?
7.
Yeah, 7 is general, but some cardiac surgeons want the HB to be maintained at 10 for the heart to be taken. So you have to consult the cardiac travel team. What is the HB target that they want to maintain and give? But what is the this is a good question. what is the downside of giving blood products to this patient? Apart from the general side effects of transfusion, there is something particularly important in this patient.
Graft rejection.
Going to do transplant.
Yeah, he may be rejection
HLA,
rates may become higher. No, blood is not HLA drawing this thing, isn't it? Basically, you are challenging the system, immune system. So you are going to put a organ into a recipient. The organ can get rejected. You are giving a organ along with antibodies to the patient. So that's not a very clever thing to do. But somebody asked about post-cardiac death. We're not going to discuss that today. There's a different topic altogether. In India, it is not very clear legally, just to give you a general impression. But since after heart stops, you are taking organs, it is post-cardiac death. Just like you take cardiac, you can take any organ that you want within the prerequisite time. But there are a lot of ifs and buts there. That's a huge topic. So HLA matching is again a transplant issue. I'm not going to get into that. Sometimes when you discuss liver or kidney transplant, you can discuss that. So sister, shall we call it a day?
Yeah, yes, sir. Actually, I think we have discussed about all the things involved in the brain dead and organ donation. So I thank you, sir, especially for your
My
time
pleasure.
and telling the things to all the students across the India. And I thank Dr. Mani and Vignesh for getting a good case for discussion.
And both of you have passed. I passed both of them. Yeah. Thank you.
Thank you, sir.
Thank you, sir.
Have a
We'll
nice
close the
evening, all
session.
of you. See you again soon. Bye.
Thank
Good
you.
night.